Good afternoon, all. Thank you for joining us for today's workshop of webinar. My name is Dipali Dhurai. I am working as a tutor. I am working as a tutor in MGM New Bombay College of Nursing, Kamakya. Today I'll be moderator for today's session. The webinar is on management of children with COVID-19. Talking regarding yesterday's webinar, regarding yesterday's seminar, we have covered the topic of severe, mild, moderate, as well as the severe COVID-19 cases. We have seen some cases also, which was dealt by Dr. Jitendra Gawane, Dr. Revati, and Dr. Suhas Kharche. Today we will be seeing further regarding the nutrition as well as the other aspects of the management of the COVID-19 children. So I would like to request Dr. Vijay Kamale sir to start with the introduction.
Good afternoon, everybody. Good afternoon, my friends from Medicine Department, Pediatric Nursing College. Actually, yesterday's first section, we have done the basic theoretical workup module regarding COVID management as told by Government of Maharashtra. But these are the rough guidelines, and we have to actually work as healthcare providers in our MGM Medical College based on local needs, local requirements, what is our local infrastructure, and for this and local manpower, and how we are going to tackle the third wave if it comes, and readiness, our preparedness for that third wave. So yesterday I had shown you certain statistics, how many patients were there in the first wave, how many patients were there in the second wave, and what will be our prediction that I will be going to talk you. And after that, what equipments, what medications, what armory we are having, and how we are going to use these equipments, medicines, how we are going to calculate the dosage related to pediatrics, then how if in any situation a resuscitation and other measures will be followed up in our MGM hospital. So for that discussions, we are having our pediatric team, and then how actual nursing management and other, because we are having Dr. Padmaja Dhavale, who is looking after since last more than 1 year in this COVID actual management to be seen. I have seen her working for day and night, so she knows which machine is where and other thing, all details. So she will be also talking, and another Dr. Sindhu Thomas, she will be detailing on her favorite topic, that is pediatric nutrition in COVID, normal children as well as sick children. So let us go back to the statistics yesterday I shown, and what will be our prediction and what we have suggested to the MGM authorities, how we are going to tackle. So as I said, first wave was everybody was admitted. So I had shown yesterday around 240 admissions. This was because everybody was getting admitted for the fear of, that was the fear wave of fear you can say. In that first wave, everybody got experience. So in the second wave, mild cases were isolated at home, and we got admission of moderate to severe cases. So we got admissions in the second wave of approximately 60 children, including neonates, out of which 12 were missed. So 1/5 were missed. So this is our experience in the second wave, what will be the thing. And yesterday, Dr. Jitendra Gawane sir said it may increase. It is not typical pediatric. Adults also will be increase. But in first wave, 5% were there. Second wave, 10% population was affected. Now possibly in third wave, 20% population, that is double. So considering that double figure, we may have admitted in the third wave and if we increase it, if we still make it double, will be around 240 maximum. But now everybody is prepared, not only our hospital, all other hospitals are also prepared. So we will not get probably 240, will get say 150 to 150 cases. That comes to 3 admissions per day. Out of these, probably 50 or 60 will be missed, that means, and we consider a wave of approximately 2 months. The experience shows that wave has not gone over more than 2 months. So if that we considered, for then 1 admission of miss per day, that is our speculation. So based on that thing, we have suggested we will be needing a 70 bedded COVID unit in our hospital. Out of which 10 will be non-COVID ICU dedicated for missed patient, because they are not infectious to other, but they will be considered as a part of the COVID. 10 will be for the serious patient, very serious patient. 10 will be HDU like. So 30 beds will be there, that we can change. It can be 30. So around 30 beds will be definitely required with ventilatory facility. They can increase to 40 also depending on the position, and 30 dedicated for a moderate severe patient or the transiting patient. So around 70 bed we have suggested, which can increase or decrease. It will increase only depending upon the position, probably to 80 or 100 also. So that is our suggestion to the authorities, and with the in a meeting with municipal commissioner also from MGM, we have submitted this proposal. We will be able to manage around 70 patients at present, and other hospitals also. So that is our modest target. So based on this modest targets, we have given the inventory list also, like how much every weekly or how much monthly will be required. So that will be talked by everybody, and based on that, what instruments and other things will be there. My faculty, which is very well versed with all their experienced faculty, they will be talking on these issues one by one. So after this introductory part, I will hand over proceedings to Anna and allow the next speaker to talk with. Thank you very much. Hello.
Next, I would like to invite Dr. Suhas Karche for talking on devices and equipments used in the COVID-19 used in the children's for COVID-19.
Thank you. So today we'll see devices and equipments in PICU. PICU in a way is very different from the adult ICU, because in adult ICU everything is fixed. The number of Foley's catheter, from the number of Foley's catheter, from the ventilating, everything is fixed. But in pediatric ICU everything is dynamic. Every equipment, every consumable will change accordingly, according to the age of the patient, according to the weight of the patient. So everything is dynamic. So what we are going to discuss today is, first, airway and resuscitation equipment; second, respiratory support devices; third, temperature regulating devices; and fourth, monitoring devices. So specifically what we are stressing is what is different from the adult ICU, because most of you are well versed with the adult ICU. So we'll focus on the facts or the precautions which we have to take, which are different from adult ICU. So airway devices. So first is the oropharyngeal airway devices. Oropharyngeal airway devices are very important in children. The reason being, if you take a ratio of tongue size to the oral cavity in pediatric age group, that ratio is higher as compared to the adults. Means tongue occupied larger portion of oral cavity as compared to adults in pediatric. So when patient become unconscious and there is a risk of tongue falling back and blocking the airway, so there comes the oral airway. So oropharyngeal airway is very important in pediatric age group. What is important is you have to choose the appropriate size of oropharyngeal airway according to the age and weight of the children. So how to choose appropriate size? What you have to do, you have to take the airway, measure the distance between the tragus to the or angle of mandible to the angle of mouth, and match that length with the airway sizes available to you, and the airway which is similar size of the distance between the angle of mandible and oral cavity, you have to choose that size of airway. If you put excessively large airway, what will happen? It will result in uvular swelling. It will cause damage to the uvula, will result in the uvular swelling, epiglottitis, and can cause airway obstruction, especially in post-operative children who are under effect of anesthesia. So this is about the oropharyngeal airway. And if you take a smaller size airway, what will happen? It will not able to maintain the airway. So appropriate size of the airway, choosing appropriate size of the airway is very important in pediatric age group. And how to choose it? You have to measure the distance between angle of mandible to the angle of mouth and match it with the airway length. Now, if you can see here, this is oropharyngeal airway, and this second picture is a nasopharyngeal airway. Nasopharyngeal airway is very rarely required in the children. It is used only when there is some contraindication to put oropharyngeal airway and you want to maintain the airway. So nasopharyngeal airway is put through nose, and the length of the nasopharyngeal airway is from the nostril to the angle of mandible. That length you have to take, but nasopharyngeal airway should be of flexible material, because adenoidal hypertrophy, which is normally present in the children, will make it more vulnerable to damage the adenoids and may cause bleeding also. So nasopharyngeal airway generally not preferred in children. If at all they are required, they can be put of a flexible rubber material. In case nasopharyngeal airway is not available, you can use a small 2 or 2.5 number endotracheal tube in place of nasopharyngeal airway. Again, the purpose of nasopharyngeal airway is the same as oropharyngeal airway, to prevent the tongue from falling back and to maintain the airway. Then second important device is endotracheal tube. Now in adult, all the nursing staff is well versed with the endotracheal tube. What is different in pediatric age group is that you have to choose the number and size of the endotracheal tube depending on weight of the child. So there are two types of the endotracheal tube. You can see in the picture, this one is a cuffed endotracheal tube and this one is an uncuffed endotracheal tube. So in all scenario, for all practical purpose, cuffed endotracheal tube is preferred over uncuffed endotracheal tube, especially in a situation when there is a hiatus hernia, if child is full stomach. In such scenario, cuffed endotracheal tube is preferred, because even if child omit, the chances of aspiration will be minimized by the cuff. Whereas uncuffed endotracheal tube is preferred in very smaller children. Nowadays, cuffed endotracheal tube are available even in the sizes of 3, but they are still in India, in this part of country, we don't get cuffed endotracheal tube less than 5 or 4.5 number. We don't get cuffed endotracheal tube. So below 4.5, we have to use uncuffed endotracheal tube only. When we use cuffed endotracheal tube, we have to make sure that we should intermittently deflate the cuff. So every 4 hourly, you have to deflate the cuff for half an hour and then again re-inflate it. Why this is important? This is important because continuous pressure on the tracheal wall may cause a tracheal pressure necrosis. So to avoid that, we have to deflate the cuff of endotracheal tube intermittently. So all other parameters of the endotracheal tube, like you can see this radio opaque line, this will guide you when you will take the x-ray. This will tell you the exact position of the endotracheal tube, where it lies. There are Murphy's eye to prevent the complete blockage of the endotracheal tube. And this is how the endotracheal tube is placed ideally. And this end is attached to the ventilator tube or AMBU bag. Now, how to choose appropriate size endotracheal tube? So there is a formula in children how to choose. What is that formula? Age in year divided by 4 plus 4. The answer of this formula, that number of ET tube you have to choose. And if you are going for cuff tube, you have to decrease it by 0.5. So suppose 8-year-old child, what number ET tube is required? 8 by 4 will be 2, and plus 4 means 6 number of ET tube uncuffed, and 5.5 will be cuff tube. So 0.5 centimeter less if you are using a cuff tube. So this is how you have to calculate the ET size. So now laryngeal mask airway. Laryngeal mask airway not usually required in pediatric age group, but there are certain scenarios where they can be life-saving. Where they can be life-saving when there is a difficult intubation, difficult airway, and you are not able to intubate that child, and that child is desaturating, you can put a laryngeal mask airway and you can ventilate via putting a ambu bag. So this is how the laryngeal mask airway is put. This is the cuff of the laryngeal mask airway. This is the dome. This is airway tube, and this is a connector, and this is a inflation line. So we first deflate this cuff. Then after deflating, we insert the laryngeal mask airway in a similar fashion. After inserting, when it gives a feeling of smugly fluids into the larynx, then we inflate this cuff. The amount of air to be pushed is written on this laryngeal mask airway, that how much amount of air you have to push to inflate this laryngeal cuff. And then you can attach a ambu bag over here and you ventilate the ventilate that child, and then till that time you can mobilize the more sophisticated devices for intubation. And but your emergency situation where you are not able to intubate the child can be taken care of by this laryngeal airway. And another advantage of this laryngeal mask airway, that it can also used in a spontaneously breathing child. Now we'll move towards the resuscitation equipments. The first and most important resuscitation equipment is the ambu bag. What is ambu bag? It is an ambulatory manual breathing unit. So it is available in different size. In adult, there is only one size, either mostly 750 ml sizes are available. But in pediatric age group, there are different size ambu bags are there. So 100 ml, which is used in very preterm neonates, 250 ml, which are used in pediatric age group, 500 ml, which is used in older kids and adolescent age group, and 750 ml is used in adults. So what are the parts of ambu bag? So ambu bag, you can see this white part. This is called as a silicone, self-inflating silicone rubber bag. This wall you can see in this schematic diagram. This wall is here, this blue wall. This is called as a pressure relief valves. What happens? Patient is desaturating, we are ambuing, and we become panic and we give too much of pressure. So there is always a danger of barotrauma. You are delivering excess of pressure to the lungs, and there may be a danger of pneumothorax. So to avoid that excess pressure delivery, there is a safety mechanism which is given in this ambu bag. This is called as a pressure release valve. So excess of pressure, this valve will be lift up, and excess of pressure will be released from here. So this is the pressure release valve. This is the self-inflating rubber chamber. There at this end you will see two connections. The bigger connection is for O2 reservoir, oxygen reservoir, and the smaller connection is for oxygen tubing. The bigger connection, which is there for oxygen reservoir, the advantage is that if you give only O2 without reservoir, if you connect only oxygen to the ambu bag without reservoir, it will give only 40% of the FiO2, 40 to 50%. But if you connect reservoir also, it will give almost 90%, 90 to 100% of FiO2 to the patient. Okay, so there is a face mask attached over here. We'll see about the face mask and what is the technique of choosing proper size face mask, that will be see ahead. But ambu bag, this is a face mask, and that mask which you are using should be a cushion mask. So this is how we ventilate a patient using mask and ambu bag. If you can see, this is called as a EC clamp technique. You can see the one thumb of the resuscitator is over the bridge of the nose, another hand another index finger is on the lower part of the mask, and third finger is at the chin. Remember, we should not keep this finger over the throat, otherwise we will asphyxiate the patient. So this third finger should always be on the chin of mandible or on the bone, so that we will not obstruct the airway. So this is called as a EC clamp technique. Why EC clamp? This forms a C, and if we take third limb, this forms a E. So this is called as the EC clamp technique. By this technique, we have to ventilate the children. Then face mask. So it is very important to choose proper size face mask to minimize the dead space. If you take too large size face mask for a children, so dead space will be more and proper ventilation will not occur, and it will also cover eyes. So what is the proper size face mask? How to choose a proper size face mask? So upper border of the face mask should come on the bridge of the nose, but it should not go over the eyes, and lower part should be on the chin. So that is how we choose the proper size face mask. Preferably face mask should be transparent, so that we can observe the color changes. We can observe whether we are pressing the nose mask, face mask too much and obstructing the nose. So preferably face mask should be transparent. The next resuscitation equipment is laryngoscope. You all know about the laryngoscope, but in pediatric age group, there are two types of blade we all know. The straighter blade are called as a Miller blade, and curved blades are called as a Macintosh blade. In pediatric age group, especially in smaller children, infant, we prefer straight blade like Miller blade. Why? Because trachea is more anterior in a infants, so it is easier to intubate infants with a straight blade. Whereas in older children and adolescent, we can use Macintosh blade also. It depends on the comfort of the resuscitator. Just to revise, you all know this. This is a handle. This is a hook on the base of the laryngoscope. This is horizontal fringe. This is vertical step, and this is a brake fluid. We should always make sure all the blades are available, all the size blades available in the ICU. The lights and battery of the laryngoscope should be daily checked, so that when we go for emergency intubation, generally a scenario is light is not working, battery is discharged. So daily in the morning, one person should be assigned to check the battery and light of the laryngoscope. Depending on the age of the children, like these blades are numbered from 0 to 5. So if the 0 is extremely preterm infant, neonate, 0 blade is required for term neonate, and 1 for infants less than 6 months, 2 for 1 to 5 years, and depending on that we can choose the blade. So respiratory support devices. So there are many respiratory support devices. One which is now for a discussion in this COVID is HFNC. It is a high flow nasal cannula. So what is high flow nasal cannula? You can see a machine over here, from which there is only one respiratory tube goes, and this nasal cannula is attached. So this is called as a high flow nasal cannula. This works on the principle that if you give a blend of oxygen and air with a high flow to a patient, that high flow will generate a PEEP and give PEEP to the lungs, and your respiratory distress will improve. So what we said, there are only two parameters we have to set when we are using HFNC. What are those two parameters? The first parameter is we have to set the FiO2. Maximum we can set FiO2 up to 60 to 70. Hello.
उसमें वो पुराना क्राइटेरिया दिया होगा, और जहाँ तुम्हारा 5 साल हो गया तो विदाउट पब्लिकेशन एंड 4 years
some disturbance, I think.
नहीं वो लिसी के पास ले है
वो सब मुझे दिया है
ना।
ये भी हमने रिकॉर्ड
पुराना वाला नहीं दिया।
Okay, so HFNC, so I will again revise, sorry for disturbance. HFNC works on the principle that if we give a blend of air and oxygen to a patient with a very high flow, it will end up in generating PEEP to a patient, and the lung capacity and lung recruitment will be there. So we can have to set only two parameters on the HFNC. One is FiO2, that generally we set about 60%, and second thing we have to set is the flow. Flow In pediatric age group, we set 2 ml per kg. Suppose patient is of 10 kg, then we set a flow of 20 ml. Okay, and then we have to monitor. There are certain contraindication for HFNC. What are those contraindication? If there is a CO2 retention, carbon dioxide retention, we cannot use HFNC. If patient is having altered sensorium or patient is in shock, HFNC is contraindicated. And we can see HFNC, we give humidified air. This is a humidifier. Okay, so this is about the HFNC. The advantage of HFNC we yesterday discussed. Again, I will repeat. It is well tolerated by pediatric population, but it is a aerosol generating device. So chances of aerosol generation are high. Then second method of giving non-invasive ventilation is by ventilator. So when we give non-invasive ventilation by ventilator, you can see the mask which are there when we use NIV by ventilator and when we use NIV by BiPAP machine are different. We have to make sure when we are using a NIV by ventilator, the mask which are there should be non-vented mask and there should be no entrainment wall to this mask, and there is a dual limb patient circuit. You can see in the picture the inspiratory limb of the ventilator circuit, and there is also expiratory limb of ventilator circuit. So when we are using non-invasive ventilation or BiPAP, CPAP by ventilator, the mask which we use should be non-vented. There should be no entrainment wall. But if we are using a non-invasive ventilation by BiPAP machine, the mask, there will be only one circuit. So, and the nasal mask also vary depending on the age. So if the patient is infant, he is less than 1 year, the nose only mask can be used because they are obligate nasal breather, and the PEEP can be given by nose only. But there will be but those masks will be vented mask, and there will be only one tubing. When we go for older kids, we have to use mask which is covering both nose and face. Again, if we are using a BiPAP machine, there will be only single limb of the circuit, but mask will be vented. And third device which is now very popular is a helmet mask. Helmet is non-vented and you have to use dual limb circuit for the helmet. Now, invasive ventilation. So invasive ventilation, you all know, it is very well like an adult, but there are few things we have to keep in mind when we are ventilating a pediatric patient on a ventilator. We have to switch on a pediatric mode. If we are on adult mode, the volume of the delivery of the pressure or volume mode, whichever mode we set, will not be appropriate. So we have to switch to a pediatric mode, and if the patient is neonate, you have to switch on the neonatal mode. First, before switching on the venti, putting a patient on invasive ventilation, we have to make sure the ventilator is containing pediatric and neonatal mode or not. Use the pediatric venti tubing. We cannot use adult tubing to a pediatric population because the volume of the adult tubing is very high. In pediatric age group, tidal volume is so small that if we use adult tubing for a pediatric patient, the dead space will be high and there will be no proper delivery of volume to a patient. So always make sure if we are ventilating a pediatric patient, there should be a pediatric venti tubing available. And if the child is less than 1 year, humidifier is must. We cannot use heat moist exchanger in a patient who is less than 1 year. In a less than 1 year child, humidifier is must to a ventilation. So this is humidifier. So how humidifier is attached to a ventilator? This is a inspiratory tube which is coming from the ventilator. It is going into the humidifier. From humidifier, the inspiratory tube is going to the endotracheal tube end, and from endotracheal tube end, the expiratory limb is coming and going to the ventilator again. And this chamber is called as a humidification chamber. There is a servo control mechanism which maintain the temperature and humidity by servo control, and it humidifies the air. It also warms the air and prevent insensible water loss and feeling of dryness of the lung, and maintain the proper lung function. So humidification is very important in pediatric age group. This is a viral filter. Remember, there is a difference between viral filter and heat moist exchanger. The purpose of both are different. What is the purpose of viral filter? The purpose of viral filter is that the viral aerosol particles which are there in the exhaled air of the patient should not contaminate in the pediatric ICU environment. So at the end of expiratory tubing, where the expiratory tubing is attached to a ventilator, this viral filter is attached so that it will prevent aerosolization of the ICU environment. So we'll see now what are the temperature regulating devices. The temperature control is very, very important in pediatric age group. Why? Because the body surface area is large as compared to body weight than in adults. They are more temperature regulating mechanism is not very mature. There is so they are and the percentage of body water in the as compared to adult is more, so they are more prone for hypothermia. So temperature regulating device is very, very important for pediatric age group. We have to maintain a normal temperature, especially in our ICU where ACs are running. These pediatric patients are more prone for hypothermia, and hypothermia is not acceptable in this age group because hypothermia will lead to metabolic acidosis. Hypothermia can lead to apnea, and hypothermia can lead to a metabolic stress also. So this is one device. There are many temperature regulating, many types of temperature regulating devices are there. In older days, we just were using pre-warm blankets to wrap the patient, but that is outdated now because those pre-warm blankets are not effective, and there is a risk of because the evaporation is not there, there is a risk of hyperthermia also. Now, warm water blankets are considered ideal for pediatric age groups. What is the warm water blankets? These are the bags, and these are the tubings for water. So these warm water, these are connected over here. This machine maintains the constant temperature of water which we set, and that water circulates through these pores of this bag, and when patient is placed on this water blanket, the temperature maintained. So this is ideal. Another thing, if the infant is less than 3 months, we can use a radiant warmer, but in radiant warmer, the child needs constant monitoring. The skin probe is attached, which will convey the skin temperature to the machine, and according to that machine, the radiant warmer percentage of heat will be decided. But if the skin probe is detached, the falsely low temperature will be detected by the machine and it will heat more. So there are chances of burn. So skin probe should be stringently monitored. And another disadvantage is it is only useful for children less than 3 months because the trolley is of very small size. So another mattress are warm air mattress. What are the warm air mattress? We just regulate. You can see the sister, she is maintaining setting the temperature. Whatever temperature we set, the air which is inflated through those air mattresses will be of that temperature, and warming will be done. Then IV fluid warmer. I already told you the hypothermia is a major risk factor for pediatric patients. So if we give IV fluid which are chilled, it will again go and cause hypothermia to a patient. For example, blood. Generally, when blood comes, it is very chilled, and that chilled blood, if we transfuse to a patient, it will cause a hypothermia. So these are fluid warmer. So what we have to do, we have to set the temperature over here, and we have to that IV set we have to pass through this channel, and that here their warming will be done. The fluid which will cross across the channel will be of the temperature which we set. So this will avoid hypothermia. So heat moist exchanger. So what is heat moist exchanger? It is used for humidification of the inspired air. What happens? Humidification generally occurs in the nostrils and pharynx and sinuses. When we intubate a patient, we put direct endotracheal tube into the trachea. We pass this humidification mechanism. So dry air will be generated if we don't humidify the air which is coming from the ventilator. So that air either is humidified by heat moist exchanger or by humidifier. So if the child is more than 1 year, we can use heat moist exchanger. How does heat moist exchanger act? There are filter pores which are there, which will consume the heat and moisture coming from the exhaled air of the patient, and when the air is coming from the ventilator, it will release that heat and moisture to that air, so that the air which is coming from the out will get humidified and will go to a lung as a humidified and warm air. So it uses patient's humidity and warmth. What is it is attached between the endotracheal tube and the venti tubing. It prevents the heat loss from the baby also, so patient also. The disadvantages are it is more prone for clogging and it cannot be used in a patient less than 1 year. We'll move towards the monitoring devices. The monitoring devices are, this is most known to everybody. This is sphygmomanometer. This is a non-invasive manual blood pressure apparatus. So what is very important is you have in pediatric age group, you have to choose a proper size of BP curve. If you choose excessively large BP curve, the blood pressure reading will be falsely low. Or if you choose small size blood pressure curve, the blood pressure will be falsely high. So choosing an appropriate size blood pressure curve is very important. So how to choose a proper size blood pressure curve? The blood pressure curve should cover 2/3 of the length of the arm, and the bladder should cover at least 60% of the diameter of the arm. So that will be the appropriate size of the blood pressure curve. Now the newer blood pressure curves are coming on where there is a mid-arm circumference is mentioned. So you can directly measure the mid-arm circumference and choose the blood pressure curve. But if the mid-arm circumference is not mentioned over the blood pressure curve, you have to check this. You have to choose a blood pressure curve in a such a way that it will cover 2/3 of the length of the arm and bladder should cover 60% of the diameter. And you should avoid prolonged inflation, because prolonged inflation will cause blood supply stoppage to that extremity. There can be fatigue, cyanosis, because in children they are more prone for this if you do prolonged infection. Then monitor. So another monitoring device is a multipara, which is always there in the ICU and HDU. What is important or what is different in pediatric age group size? You have to choose a pediatric size SpO2 probe. There are two types of pediatric SpO2 probe. This is a reusable pediatric SpO2 probe, and this is a disposable pediatric SpO2 probe. The adult size pediatric SpO2 probe do not fit into the finger of patient, because diameter of the pediatric patient is small, so it will give a wrong reading or it may not detect also. So this is a multipara. You can see there is ECG in it. There can be a invasive blood pressure monitoring. There is a respiratory rate monitoring. Okay. So this is it. So I cannot prepare a slide for summary. So I will summarize 3 points. What is the summary? Is in pediatric population, everything is dynamic. All the consumable, all the instrument you have to choose according to the patient's size, age, and weight. All the sizes of the resuscitation equipment, right from ambu bag, laryngoscope blade, face mask, should be available and should be daily checked. Temperature regulation is very important in pediatric population, and temperature regulating devices are must in the pediatric ICU. So that is a take-home message. Thank you.
Hello. Thank you, Dr. Suhas Karsher, for the informative session, for giving in detail idea regarding the devices and equipments which will be used in the children during COVID-19. For the next session, I would like to call Dr. Prakruti. Dr. Prakruti Kredi, ma'am has completed her MD DNP. Currently, she is working as an assistant professor in the Department of Pediatrics Mahatma Gandhi Mission Medical College, Navi Mumbai. She has past work experience as a senior resident from Bangalore Medical College and Research Institute. She has awards. First is a zonal level quiz competition of NNF 2017. She is a third prize. She has won the third prize for paper presentation at National PDCon 2017. Her area of interest is neonatology and endocrinology. She is a very passionate about teaching and is a resource person for ECLS workshop at RGUHS University Bangalore. Over to you, ma'am.
Thank you. Good afternoon. Thank you for giving me an opportunity to be a part of this informative webinar. So my topic for today is common drugs and fluid calculation in pediatrics. So as you all know that you are very well trained in adult medicine, adult medication and fluid administration. And most of you may not be trained, exposed towards pediatric wards. So everyone has some panic when they are exposed to pediatric patient, like how to administer drug, how to administer fluid. So that is the motive behind including this session. So let's start the talk. How is pediatric dosage calculation different than adults? So there is no single standard dose. Like for example, in adults, when you give like paracetamol, you will tell either give 500 mg or you give 650 mg. But that can't be done in pediatrics. Always, all the doses are calculated based on the body weight in kilograms, or when required, we calculate on body surface area. For example, in case of nephrotic syndrome, when child is having lot of edema, in such cases, we calculate based on body surface area. Otherwise, you all have to remember that all the recommended doses are calculated based on body weight in kilograms. You can't give one standard dose for pediatric age group. So what are the units of measurement? 1 gram is equal to 1000 milligram. 1 milligram is equal to 1000 microgram. 1 microgram is equal to 1000 nanogram. And 1 liter is equal to 1000 milliliters. This is very important when you're converting a drug. For example, if you're taking a drug based on weight, it is given in grams, you want to convert into, we usually tell everything into mg per kg. So this, everyone has to know this conversion. Next, how do you calculate the volume of drug to be administered? There is a simple formula, like volume of drug to be administered is equal to what you want, that is the strength required, divided by what you have, that is the stock strength we call, that is the total dosage available in the particular drug, into how much is the volume of drug. For example, we'll take simple examples. So example 1, you need to administer 150 milligram of paracetamol. The dose strength available is 250 mg paracetamol in 5 ml. So this will be there with you. There will be a paracetamol suspension bottle which would have written on its outer cover whether it is 250 mg in 5 ml or it can be 150 mg per 5 ml. So you have to always cross check. In pediatric, the main important thing is you will have to always cross check how much mg is there per ml. Then only you can calculate the required drug dose. So for example, now what you want 150 mg of paracetamol. What you have, the strength is 250 mg. So 150 divided by 250. And what is the volume in 5 ml? So 150 into 250 multiplied by 5, it gives 3 ml. So the drug needs to be administered is 3 ml. So this is for a oral medication. Let us take an example for IV medication. For example, you have a 2-year-old child weighing 10 kg. who presents to the emergency unit with convulsion. And they have prescribed intravenous anticonvulsant midazolam, and they've written, like some doctor has written, 0.1 mg per kg. And the strength of the drug, when you look at the vial, it is given like 10 mg in 10 ml. So now how do you calculate this? So you know the weight of the child, you know how much mg you have to give per kg, and you have the strength. So let us simply calculate it. So step 1 is calculate the dose to be administered. How do you calculate? You know 0.1 mg per kg. Kg is 10 kg. So 0.1 into 10 will be 1 mg. Next step will be calculate the volume of the drug to be administered. So again, let us go back to that formula. Strength of the drug required by drug strength into volume of the drug. So now what is the strength of the drug required here? 1 mg. What is the drug strength? It is again 10 mg. You know that 10 mg. Then volume of drug required, volume of the drug in that vial is 10 ml. So that gives you 1 ml. This 1 ml you will have to dilute appropriately, like by using 4 ml NS, and then administer IV slowly over 3 to 5 minutes. So this formula should be remembered so that it will be easy to calculate the any drug. If you know what is the strength, drug strength, and this all three will be easily available, you just have to make some simple calculation so that it will give you the volume of drug to be administered. So next, I'll be discussing like common dosages of drugs in relation to your COVID-19, what all commonly will come across like to administer drugs. So I've divided into oral route and intravenous route. First, let us see the dosages of the drugs which are given orally. The most common drug is paracetamol. So you all know the indication when to give all these drugs. So paracetamol, when there is fever, you would have given. What is the standard dose? 10 to 15 mg per kg per dose every 4 to 6 hourly. What is the maximum dose you can give? Is 90 mg per kg 24 hour or a cumulative dose of 4 gram per 24 hour. We need to know the maximum dose because we have kids weighing from 2 to 3 kg to adolescents who are obese will be weighing 65, 70 also. So we always need to know the maximum dose of drugs. So amoxicillin, it is 25 to 50 mg per kg 24 hours every 8 to 12 hourly. So maximum is 2 to 3 gram per 24 hour. Aspirin, it is indicated in case of your moderate to severe COVID, when there is involvement of coronary vessels and all, or when your coagulation parameters are dearranged, give at a dose of 3 to 5 mg per kg per 24 hour OD. The maximum in COVID is 81 mg they tell, but it I can't generally put it here because in different illness you give different. So in COVID it is maximum dose you can give aspirin is 81 mg according to guidelines. Azithromycin 10 mg per kg per dose OD, it is given once daily only. Maximum you can give is 500 mg once daily. So then cetirizine, it is an antihistaminic. We usually don't use it less than 6 months. So up to 2 years, it is 2.5 mg once daily. 2 to 5 years, it is 5 mg once daily. Then 6 to 12 years, it is 5 to 10 mg once daily. So the maximum dose again here, it will be 10 mg. So coming to intravenous drugs, which are used commonly in COVID scenarios. One is antibiotics, then steroids. Antibiotics, you can use amikacin sulfate when indicated only. The dose is 15 mg per kg per 24 hours every 8 to 2. Usually we give it BD dose, and maximum dose is 1.5 gram per 24 hours. Ceftriaxone 75 to 100 mg per kg per 24 hours BD. Maximum dose is 2 gram per dose or 4 gram per 24 hours. You will always have to remember here the difference between these amikacin and ceftriaxone, like most commonly used drugs. Mainly we use ceftriaxone in ICU, maybe when child is ventilated, or maybe you have suspected any superadded bacterial infection, then you will give ceftriaxone. So there is concentration dependent killing. So this ceftriaxone you need to dilute. You should never give it directly the diluted drug. The diluted drug should be again diluted in your around 20 to 30 ml of NS and infused over 30 minutes to 1 hour. You can't directly push in like a bolus ceftriaxone. Even amikacin should be given slowly, because rapidly if you push it, even that ototoxicity is high. So, but always remember ceftriaxone has to be given over infusion. Then dexamethasone. So 0.15 mg per kg per 24 hour once daily. Maximum you can give is 6 mg once daily. So this also we include when as and when there is indication to start steroids in COVID-19 children. So adrenaline, we use it for resuscitation. 1:10,000 dilution, 0.1 ml per kg. Maximum you can give is 1 mg. See, for example, in adults, you might have used directly 1 mg, like dilute and give total 1 mg. In pediatric, you always have to calculate this. The diluted solution, you will have to calculate again 0.1 ml per kg. For example, roughly the child is 6 kg. Then you will have to give only 0.6 ml, and you can repeat it as and when required after every 3 minutes. Then methylprednisolone, it is also indicated in case of your COVID or in case of your MISC, moderate MISC, 1 to 2 mg per kg per day. Maximum you can go is 60 mg. But in case of severe MISC and all, you can use 10 to 30 mg per kg per day of IV methylprednisolone. Even that has to be diluted and given slowly over 2 to 4 hours. Then other drugs which are used as and when indicated in COVID are enoxaparin, that is your low molecular weight heparin. If the infant is less than 2 months, then you will give 1.5 mg per kg per dose every 12th hourly. Here the route is subcutaneous. And if it is more than 2-month-old infant up to adult, like to adolescents also, you can use 1 mg per kg per dose BD subcutaneously. So I thought I'll include amphotericin B drugs, because as mucormycosis case is on the search, we are not seeing any pediatric case, but still I thought it will be useful. So amphotericin B, there are two forms. One is conventional amphotericin B, other one is liposomal amphotericin B. See, the conventional amphotericin B, always you will have to reconstitute in the water given for that injection, along with that injection, and then you will have to dilute again with 5% dextrose to make it a concentration of 0.1 mg per ml if you are administering through a peripheral line, or 0.25 mg per ml if it is central line. So you have to make sure this concentration is achieved when you are diluting with your 5% dextrose. Again, you can use the same formula which we have discussed earlier for dilution purpose. So this diluted drug, initially we give a loading dose of 0.25 to 0.5 mg per kg per day over 2 to 6 hours. Then you increase as tolerated by the child to 0.5 to 1.5 mg per kg once daily, once increment per day. So the maximum dose is 1 to 1.5 mg per kg per 24 hours. Until you reach this dose, you can have everyday increment of 0.25 to 0.5. So next, liposomal amphotericin. Here also the reconstitution is with 5% dextrose. Here there is no increment in dose daily as you have seen with conventional dose. Here from first day only you give 5 mg per kg per day IV, once daily dosing it is. In case of CNS involvement and severe infections, you can go up to 10 mg per kg per 24 hours. So while the child is on amphotericin B, you will have to monitor renal parameters, hepatic and liver enzymes, electrolytes, and your platelet counts also to look for the side effects of the drug. So this completes our drug calculations and drug dosage. Next, we'll move on to fluid. So in fluid, in pediatric, we'll have like maintenance fluid, replacement fluid, deficit fluid. So that maintenance fluid is of most important here. So we'll discuss that under the following heading: when to give, how much to give, how to give, and what to give. So maintenance fluid means it is the fluid when given for a child who is kept NPO, or who is in a child who cannot be fed enterally, for indications like if child is on ventilator, invasive ventilation or non-invasive ventilation, child's GCS is low, you're not able, distress is more, then we have the risk of aspiration. In such situation, we'll have to start the child on maintenance fluid. See, even though for an adult, maybe they can tolerate 12 to 18 hours of being kept NPO without any hypoglycemia or electrolyte imbalance. But that doesn't hold good for a child. A child, even though for like if it's an infant, for example, a 6-month-old, 8-month-old baby, even a 6 hour of fasting, they cannot tolerate it. So in such situation, when the child cannot be fed enterally, always you will have to start maintenance fluid. Why it is called maintenance fluid? This fluid, what we give is to maintain the normal calorie requirement and electrolyte requirement for that child, so that it will not cause weight loss and protein catabolism. So we give maintenance fluid. So how much do we give? This is very important, this table. So how much do we give? Based on the body weight. Again here, see, for example, in an adult, you might tell we'll give 100 ml per kg per hour, or you might tell that we'll transfuse 2 pints today or 3 pints. And again, you might have not divided it into per hour also. You would have given morning and evening, and then at night you feel okay, then you stop it. In children, you can't do that because their body weight is low. So if you give more fluid, that will cause fluid overload. They can't tolerate it. The cardiac can't take care of it if you overload the child. So always you will have to give the fluid based on body weight. So body weight, if it is 0 to 10 kg, then fluid per day is calculated as 100 ml per kg per day. Per hour also there is a calculation, that is 4 ml per kg per hour. Either of them, if you remember, is also sufficient. So 0 to 10 kg, you calculate it as 100 ml per kg per day. Then 11 to 20 kg. So this 1000 ml is taken as a base for the first 10 kgs. After that, above 11 to 20, what we do is for every kg, we add 50 ml. Then about 20 kg, it is 1500 ml as the base, plus 20 ml per kg for each kg above 20 kg. So the maximum fluid which we can administer per hour is 100 ml per hour, or per day is 2400 ml per 24 hours. This is the maximum maintenance fluid we can administer. Whatever might be the weight of the child. So irrespectively if the weight is more and you're getting 120 maintenance fluid ml, 120 ml per hour, no, you can't give that. You will have to stick on to the maximum fluid tolerated by a person, that is 100 ml per hour. So how to give? How do you give fluids? There are many ways to give intravenous fluids. One is through your infusion sets, like your pediatric drip set, macro drip set, micro drip set, and electronic devices, either infusion pump or syringe pump. So this is a pedia set. See, the advantage of using pedia set is, first of all, here you can accommodate only around 100 to 150 ml of fluid. There is less chance of fluid overload with this, and it is easy to calculate how much of fluid has gone. So you will have the markings on this, and it is useful when you are diluting the drug and infusing it. For example, you want to administer an antibiotic or an anticonvulsant. You know that the diluting fluid you would have taken 30 ml. So there are markings in this 30 ml, so that you can take up to this 30 ml and add the drug and then infuse it. So that is the advantage of pedia set. So this is how an infusion pump looks like. Here you need not, Here you need not calculate the drops, count the drops and calculate it. If you set it, it will deliver at a set rate. So less error with this infusion pump, and when load is very high, it is better to use electronic devices so that error will be less. And this is the practical point. pediatric drip set 1 ml is equal to 60 drops. So if you want, like for example, how to calculate ml per hour. Ml per hour is equal to drops per minute. For example, if a child of 10 kg requires maintenance fluid of 4 ml per hour, so that will be how much then? 4 drops per minute. So ml per hour is equal to drops per minute. That is the basic in pediatric drip set. But it is same in your micro drip set also. But macro drip set, there is a variation. 1 ml is equal to 15 to 20 drops. So this is useful when you are manually counting the drip rate. For example, you are short of infusion pumps, you are short of pedia set, you are short of micro drip set, then you will have to use macro drip set. Otherwise, which you will usually we won't be using macro drip set. So when you're manually counting, you take that approximately, it usually depends on the manufacturer. So roughly we take 15 to 20 drops is equal to 1 ml. You can take like 16 drops. You count 16 drops in a minute. That tells you that, okay, 1 ml of fluid is getting infused now. So that way you have to calculate. So then how will you get to know if how much ml per hour has gone, the fluid? For that, a simple example, ml per hour divided by 4 is equal to drops per minute. We'll do it with the example so that understanding will be better. If the infusion rate, this is for your macro drip set, micro and pedia set are simple. Ml per hour is equal to drops per minute. But here you will have to do some calculation. Here, if you want a maintenance fluid of 40 ml per hour, then you will have to divide that 40 ml per hour divided by 4. That will give 10. So you will count at 10 drops per minute. So in a macro drip set, if you set the drip rate at 10 drops per minute, that will deliver 40 ml per hour. Next, what is the choice of fluid? What is the choice of maintenance fluid? It is usually 0.9% NS, normal saline, with 5% dextrose and 1 ml KCl per every 100 ml of fluid. This is the maintenance fluid of choice. It is simple that your DNS, dextrose normal saline, 0.9% with 1 cc KCl per 100 ml of fluid. If you are giving for, if you are adding the full 500 ml fluid, if you are mixing it with KCl, then you will add 5 ml of KCl. And then you will have to set the drip rate accordingly. So how to calculate flow rate? So volume in ml, the rate is equal to volume in ml by time in hours. For example, you are calculating a maintenance fluid for a 3-year-old child weighing 14 kg. So you know the weight of the child, you know the how much fluid to give with that formula. What is that? 1000 ml base for 10 kg, then extra 4 kg. I'm taking 50 ml per kg. So 50 into 4, that will be 1200 in 24 hours. So what is the rate now? With rate 1200. This is the fluid per hour, per day. So divided by, you want it per hour, divided by 24 hours will give you 50 ml per hour. So the rate here to be infused is 50 ml per hour. So this simple formula will help you know the flow rate of IV fluids. Next, by this second example, you will have to know that in an adult, if you are giving maintenance fluid and along with that you are giving some antibiotics, anticonvulsant infusion, you need not minus it, because for them the extra 20-30 ml fluid may not be harmful. But in a pediatric child, you giving extra fluids when you're diluting, for example, for antibiotic ceftriaxone, you would have taken 30 ml, you have given it BD, then you have given some methylprednisolone, that also would have diluted. If you don't minus that from your maintenance fluid, there are high chance of fluid overload, and that too in a condition where child is intubated or child is having convulsion or child is sick, then there will be fluid retention in the body. So you'll always have to maintain minus the whatever diluent fluid you have used from the maintenance fluid. For example, calculate maintenance fluid for 1-year-old child weighing 10 kg. and child is receiving ceftriaxone and fosfenetone injection intravenously BD. 20 ml NS was used for diluting each medication. So here we'll also go stepwise. Step 1 is first you will calculate the maintenance fluid for this child. So what is the maintenance fluid required for 24 hours? It is 100 ml per kg. So child is 10 kg. So 10 into 100 is 1000 ml per 24 hours. Next step is total amount of fluid used to dilute medication. How much amount of fluid was used here for dilution? It is mentioned here that 20 ml was used for each medication. So ceftriaxone is given BD, so 2 times, and fosfenetone is also given BD, so 2 times, so 4. So 20 into 4, 80 is the diluent fluid used for this child. So subtract the diluent fluid from maintenance fluid, that is 1000 ml minus 80, 920 ml in 24 hours, and you will be getting 38 ml per hour. This is very important when you are dealing with a sick child, and all pediatric age group, you will have to minus when you are giving a large any other medication with large amount of dilution. If it is 1 to 2, like 4 ml, 5 ml diluent you are using in a day, that is fine. But once you cross about 10-20 ml per kg, then you will have to minus it from your maintenance fluid. So what is the take-home message? Understand units of measurement, that is conversion from gram to milligram, milligram to nanogram. Then possess sound knowledge of calculation formulas. Estimate the required volume of drug and or number of tablets, always based on weight of the child. No single standard dose. Then double check when appropriate. This is very essential. Always when you are calculating, maybe for example, a inotrope or a anticonvulsant, you will always have to cross check it. Cross check in the sense, two individuals will calculate it separately, and then you cross check whether it is same or whether it is any different. This will minimize your error. And always, as you know, the standard when you are administering a drug, you will always have to see, cross check whether it is the same child, IP number is same, the basic details you will have to check, and cross check the weight of the child. This will minimize the error. Thank you.
Thank you, ma'am, for taking in detail session on the drug calculation and the dosage. Also revising everyone for the drug calculation formulas, and talking about oral and IV drugs as per the age criteria. Also talking on fluid for maintenance, which is being given after once the child has been admitted. And surely all will remember the points which was covered in your session. Thank you, ma'am. Next, I would like to invite our next speaker, Dr. Mrs. Sindhu Thomas, PhD in nursing, MSc nursing, MSc in counseling psychology, BSc nurse. She has a teaching. She is a teaching faculty in MGM in Bimam since 2009, working bedside as a RN for 2.5 years, certified parenting coach, counselor for adolescent and adult issues, published articles in peer-reviewed journals, and secured awards for oral and poster presentations, hosting 2 YouTube channels on parenting and on psychological approach for mental issues, as well as she has secured first rank in MSc in 2012. Over to you, ma'am.
A warm good afternoon to all the respected medical team as well as the faculty of MGM New Bombay College of Nursing. We are really privileged to be a part of a well-organized medical team where you are really taking good effort in very meticulously giving out points so that a third current can happen. And if the pediatric people are going to be affected, you are really acknowledging all the people who are in the hospital setup to take care of it. So a great thanks from MGM New Bombay College of Nursing. Also, I would like to give my thanks to Dr. Prabhaki Daisila ma'am, Director of MGM New Bombay College of Nursing, to organize this session and giving us a chance. Over to the topic. So the topic given to me is nutrition management in COVID-19. As we know that the major chunk of the population is not affected because pediatric is not affected, and we pray that nothing will happen to the pediatric session as well. So as explained the previous day, according to the Maharashtra's Pediatric Task Force that is live stream on 23rd of May 2021, that SARS-CoV in children can be presented in two ways. That is acute COVID illness as well as multi-system inflammatory syndrome that can be in children as well as in neonates. So as explained yesterday also by Dr. Jitendra Gawane, the all pediatric cases can be seen mainly an asymptomatic as well as mild form, that is 95%, whereas less than 5% is expected to be in moderate, and severe can be pneumonia and MISC and as well as MISN. So we are going to deal with how to take care of the nutrition aspect, which comes under the supportive management of a medical treatment. And this is mainly of a preventive aspect so that we can prevent from the newborn time from the attack of COVID. So coming to the neonate and infant, it is well documented that there is no vertical transmission of COVID. That is, that from the mother, there is no chance for the newborn to get the COVID infection. It is seen by the research activities, whereas the amniotic fluid of the mothers has been tested along with the cord blood as well as the swab of the infants delivered by C-section, and it is found to be negative according to RT-PCR test. Also, there is no research that shows that the breast milk can transfer the infection, only the horizontal transmission, that if the mother or the caretaker has a COVID infection, there is a high chance for the child to get the infection. Coming to the breastfeeding practices, according to IYCF recommendations of COVID time, that is of last year, and it is saying that the global guidelines are still the same even in the COVID time period, that we are supposed to initiate breastfeeding within 1 hour of birth, and exclusively we need to breastfeed the children on first 6 months, and we need to introduce complementary feeding from 6 months of age up to 2 years of age, and we can continue breastfeeding more than 2 years of age till the child and mother agreed for the same. Now we are coming to see different cases where how we can practice, or what are things we can practice in case of breastfeeding. If the mother and child is positive, there is nothing to worry. Give them time to both of them. They will be recovering as time goes by. But if the mother is tested positive and the newborn is tested negative, what we can do is first we need to counsel the mother for breastfeeding, because out of the fear, the mother may not be able to give breast milk to the child, and it's good to have an informed consent. Also, we need to emphasize the need of telling them the need of immunity development, even though the mother is COVID positive, because the breast milk is the best milk any infant can have. And both the mother and the assistant should wear a mask when feeding or carrying the baby until both are recovered completely. Also, encourage them to wash hands with soap and water for 20 minutes before and after contacting the baby. And we need to maintain the respiratory etiquettes, that is, cover the mouth and nose with a bent elbow or a tissue to prevent droplet from spraying. And later, we need to safely dispose whatever had been used. Wash the hands with soap and water afterwards for 20 seconds, as explained before. We can practice rooming in with a distance of 6 feet unless we are breastfeeding the child. And in the next case, if the mother is not at all able to breastfeed the child, we can go for an expression of the breast milk. And as we know that we can manually do with hand expression, as well as you can have a breast pump, manual breast pump, as well as an electronic breast pump. And whatever you are using, we need to follow the normal or the real way of doing things. That is, use a sterilized bowl and spoon for giving the express breast milk, maintain the hygienic practices. Even you are expressing the breast milk, feeding the milk to the child, or giving an infant formula, maintain all the precautions to prevent the transmission of the child, and see for any signs of dehydration or malnourishment of the child, and we can start ORS if signs of dehydration is there in the baby. Now we are coming after that we are going to take care of the child after 6 months of age. There is a case to how to give a complementary feed if the mother or the caretaker is positive and the child is negative. Practice safe complementary feeding, and we know that the complementary feeding needs to be started at the age of 6 months. Wash the hands before preparing the food and after feeding the baby. Before feeding the baby. Clean the food preparation areas. Wherever you are preparing the food, you should make sure that the hygiene is well maintained. And wear a mask while preparing the food. Maintain the respiratory etiquettes. Feed the baby with clean or a sterile, or that is by boiling and cooling. We can sterilize things at home setup, because home care is prescribed for asymptomatic and mild care of COVID in children. And as the IYCF has given before, all principles can be followed same. That is about the frequency, amount, thickness, variety, responsive feeding, as well as the hygiene. Along with that, the common things what we need to be taken care is, do not force the child to eat the food whatever is given, because feed what is asked by the child or till the child is interested. And we know that include all the fruits, vegetables, legumes, and animal source, as well as means the egg, meat, poultry, fish, and dairy products. And we can avoid high sugar and salt and fat, which is mainly seen in fried food items, sweets, juices, and salted snacks. And do not give food that is pre-chewed to child, because these things are commonly seen in the community setting. That's why it is well written in IYCF booklet. And if the child gets sick, give extra fruits in food to recover faster. Breastfeed the child and encourage the child to eat soft food during the sickness, and make sure that after the sickness increase the feed twice, means with one meal or two meal for next 2 weeks or 1 week to regain the strength of the child. If the child is negative and because of the care, because of the horizontal transmission, if the child is showing the symptoms, we can check for the COVID-19 symptoms, that is fever, dry cough, and difficulty in breathing. And some of the nutritional aspect is the child can be refusal of feed can be presented along with vomiting and diarrhea. And along with that, others are explained about convulsions, chest retractions, and fever. And if any signs of malnutrition, we can take the baby to the hospital. Now this is coming to the moderate feeding. If the child is presented with red flag symptoms, and how we are going to manage the nutritional aspect of the child. Oral feeds can be continued based on the food tolerance of the child. If not, we can proceed with the rice tube feeding, maintain the IO chart, and usually formula feed will be used because the most of the hospital protocols has been followed. And one of the composition what we use in our hospital is rice dal powder mix, especially in case of suspected malnutrition. So here we use 3 kilo of parboiled rice with 2 kilo of moong dal. We wash and dry and powder it, fry the powder, and mainly keep in the airtight container. So whenever it is needed, we can take 10 scoops of R&D powder in 100 ml of water with 1 teaspoon of sugar and 1 teaspoon of edible oil with a pinch of salt, and boil it. Add boiled cold water to maintain the consistency adequate for an RT feed. And in case of severe COVID condition, total parenteral nutrition can be considered if it is prescribed. Now we are going to tell what are the common food items we can advise to mother if the infant is more than 6 months of age. We need to encourage the mother because breastfeeding still is the best food for the child. And along with the breast milk, they need to start with other food as well as. So if the child is 6 to 8 months, we can start with 2 to 3 times of feeding along with breastfeeding. And if the child is of 6 to 8 months, 3 to 4 times of feeding can be asked. And whenever you are giving the food, half katori or half portion of the plate can be expected to be have by the child. And along with this condition, if the child is presented with cold and cough or any respiratory symptoms where the child can have food, barley water and rice gruel are advisable, because even culture practices the same and there are effects of the same thing where the child can have more amount of fluids during this particular time. If the infant is more than 1 year, again continue breastfeeding and make sure that we give more warm fluids and healthy snacks. Steamed banana puree as well as stewed apple or apple sauce can be given. Apple sauce need to be given immediately because the color can be turned. And along with that, turmeric milk is given along with a little amount of pepper and palm candy, because sugar is avoided, sugar and salt is avoided in childhood because of not well developed taste buds in children. And along with that, we can give vegetable as well as chicken clear soup, tomato soup, and apple carrot soup. Along with that, we can offer them the citrus fruit juices. That is, there are rich sources of vitamin C. That is lemon or orange with warm water. Along with honey can be given once the child is more than 1 year. Avoid spicy as well as fatty food in case of diarrhea. ORS and 6 supplements can be given as prescribed. Now we are going to deal with the toddlers, that is the soft diet we can think of giving to this particular age, where we can concentrate on moong dal khichdi or curd rice, and the curd should not be chilled or not that so. Then we can prefer oatmeal, dalia porridge, sabudana or sago porridge, idli or dosa, rice porridge, and upma or shira. So we need to understand that we need to teach the mother. Mother may be knowing all these things, but at the time of hospitalization or in the time of crisis, the mother may not be even remembering what to be given to these children. So this can be an added information you can give to the mothers to feed the children, so that the nutritional status can be maintained. And once the child is in the recovery phase, what we can do is we can encourage the mother to add one more meal, that is solid food per day for next 2 weeks, along with increase in the frequency of breastfeeding. Coming to children, children includes all the children and adolescents. We can ask them for a regular diet, that is 3 meals plus 2 healthy snacks. Also, we can consider a broad diet, which includes banana, rice, stewed apple, and toast in case of upset stomach. It is recommended, what means nearly a 10 decades ago, because of the blunt nature and easy to digest. But the issue with this particular diet is it is not meeting the nutritional needs of the child. But for an upset stomach, this diet is still followed. And as Kamala sir is explaining about the psychological effect of sickness of children, that psychological effect can be seen from an infant to an adolescent. There is no change. The baby will be clinging to the mother, or the child will be clinging to the mother, because they are feeling sick at the time of any kind of illness. So psychological support is needed for the child as well as the mother. Coming to the nutritional assessment. So nutritional assessment, as we know that we always go for a dietary recall to see what the condition of the child, whether the complementary feeding is given to the child, or breast milk is given to the child, or the child is getting adequate diet. So this way we can have a nutritional record. Along with that, the nutrition assessment mainly consider of this anthropometric measurements, whereas it consists of the weight of the child, length or height according to the growth of the child. Then we will be assessing the head circumference, chest circumference, and mid-arm circumference of the child. And we know that we calculate the degree of malnourishment, and usually we go for an IAP formula for calculating the degree of malnourishment. Along with that, weight is the most sensitive indicator. We go for weight for age in young children, and we know that less than 2 standard deviation is considered to be malnourished. Along with that, we check for the clinical manifestation if any kind of deficiencies are there in the children. Along with that, we can get the help of lab investigation to see the nutritional status of the child and plan for a new diet for the child, along with the nutritional counseling, because mother or the caretaker plays an important role while taking care of the child. Now the concern of this lockdown is obesity. So other than this, children those were affected, other children due to the lack of outdoor activities, and there is no routine for them. So obesity is also a highlight during this lockdown. So what we can advise them to have a healthy eating and an increased physical activity, less screen time, and sleep full night, because we know how media is going to be affected in this particular age group. So here ends the session on nutritional aspect, where we have dealt the entire thing that is in the preventive aspect. If the mother and the child are together in rooming in practice, that is immediately after delivery, what we need to follow so that the baby or the infant or the newborn is not going to be affected with the COVID infection. And if the COVID infection is affected, and how as a caretaker I can identify and take care of the COVID thing. And along with that, the toddlers and schoolers and adolescents need to be taken care because of COVID infection. And now the concept, as we already said, that the obesity. The last before winding up my session, yesterday one question has come up that what would need to be done to prevent COVID infection. If that food has been discovered, we all would have eaten and we all will be happy to be out of this particular infection. So this concept of my plate explains what kind of nutrition I need to take from the childhood for an adolescent, which is accredited already, that half of my plate means half of my plate should be filled with fruits as well as vegetables, and 1/4 will be with grains and other quarter will be with proteins. Also, I need to have a serving of dairy on my plate. This is a simple example of the food pyramid we usually see in a daily basis. So with this, I'm ending up with my session. Hope you are able to understand what has been explained. Thank you.
Thank you, ma'am. It was an informative session. The nutritional practices discussed was regarding breastfeeding and complementary feeding was very informative and will surely be followed. And as well as how much the nutrition assessment was important, it was discussed by you. It was very informative. Thank you. Next, I would like to announce our next speaker. Dr. Padmaja Dhawale. She is serving nursing profession for last 28 years since 1993. She has completed PhD nursing in 2021 with specialization in pediatric and has achieved additional qualification in MBA in healthcare services from Sikkim Manipal University. She has clinical teaching and administrative experience. She continued to carry dual responsibilities as faculty and nursing superintendent in MGM New Bombay College of Nursing and MGM Hospital Kamuthi. She contributed in getting NABH accreditation for MGM Hospital Navi Mumbai. She handled COVID pandemic situation during 2020-21, conduct CNE and in-service education programs for nurses for keeping them abreast with the current knowledge, encourages nurses for conducting nursing research and motivating nurses for higher education. Over to you, ma'am.
Thank you, Ms. Dipali. Yeah, I thank MGM College of Nursing, New Bombay College of Nursing for organizing such a good session to abreast with the information on COVID-19 among children. Now we are going to face the third wave of COVID-19. So that is why we are making aware everyone to deal with if at all this third wave comes. Hope it does not come. Yeah, today we are going to see discuss on nursing management of critically ill child in COVID-19. As we know that the children are at very high risk of developing any kind of infection, especially with the COVID-19, which has been thought that it is less common among children as per the data what is available. And young children, especially less than 1 year of age, they are more vulnerable for acquiring this COVID-19 due to their immunity response. Now, according to the data, what has been presented and published, it says that less than 20% of infants are symptomatic, those who require hospitalization, including comorbidities. Whereas 1 to 3% out of these 20%, those who are symptomatic children may have a severe illness and who may require intensive care admission. So majority of the children are asymptomatic, but later they may present with the post-COVID complications like multisystem inflammatory syndrome. And similarly, when we say that these children are more vulnerable among age group of less than 1 year, which shows that the older children are likely due to the older children are less vulnerable for this COVID as their immunity has developed well. But even though these younger children, they are immature in their immune system and the smaller airway, which make them more likely to develop a breathing issues with the respiratory virus infection. As we know that this COVID-19, which affects the respiratory system itself. Another studies, it has been presented that boys are more commonly affected than the girls, and most children were either asymptomatic or mildly symptomatic, In this children, those who are younger than 3 years and those with the congenital disease seem to be disproportionately impacted. In the yesterday's session, and Dr. Revati Madam as well as Dr. Khatsure regarding the mild illness, moderate illness, and severe illness, but just thinking of that, mild illness can be managed at home except those with the comorbidity. So children, those who are having a comorbidity need a admission in the hospital. It will be very difficult to manage at home if it is not monitored properly by the parents and not reported in time. Moderate illness and severe illness do require admission in the hospital with a proper monitoring for the progress of the condition, as well as hydration level has to be maintained properly with the supportive care and medications. Severe illnesses, usually it will be presented with the ARDS, pneumonia, sepsis, shock, or multi-organ disorder. And the new thing that is a post-COVID complications, what we see among the children nowadays is multisystem inflammatory syndrome, which is a new syndrome that occurs in the minority of the children with the prior SARS COVID infection. Now, what is important when we care for the patient? As you all know that the nurses are the pivotal in caring in healthcare sectors, who is like a backbone for caring the patients during this pandemic. So we have to ensure for all the healthcare workers for their vaccination, everyone should get vaccinated and then they are exposed for the caring. But initially in 2020, this vaccination was not available. But now when it is available, this healthcare workers need to be vaccinated before they enter the area. Managing these cases in isolation is very, very important because as you know that this COVID-19 is communicable and we have to protect the healthcare workers as well as protect the spread of this infection. Now to protect the healthcare worker, definitely the healthcare worker has to follow proper donning doffing by wearing the PPE kit and following the policy of donning doffing with a demarcation of the area. Proper disinfection of the area and disposal of the COVID waste is also important. So along with the nursing care, before that when we think of, we have to think of the area, the organization of the ICU or the area where the cases will be managed and the protection of the healthcare worker. Now, yes, thinking of this nursing management of mild cases, as discussed yesterday, it is like these children may present with the sore throat, rhinorrhea, cough with no breathing difficulty, and few may present with the gastrointestinal symptoms like diarrhea. So the medications will be prescribed by the doctors and these medications need to be administered to the child. Now at home setting, the parents will be taking care of the child and the parents need to be educated well for administering the medication, when, how and how much it has to be given. So parent involvement is very, very important in the child care, even the child is at home or whether the child is in the hospital. Educating to the parent for proper monitoring of the symptoms and progress of the disease. Similarly, they should be also given information for the warning sign, administration of the paracetamol syrup whenever it is necessary, or the parent can be taught how to do the tepid sponging if at all the fever rises. For sore throat, some warm gargles can be given. Now, this can be used for little older children. Soothing cough syrup can be advised. Now, hydration and adequate nutrition has to be taken care. In case of young infants, insisting on breastfeeding, a nutritious diet which includes the high protein, vitamins and minerals should be encouraged in or should be given for the older children. Young infants, those who can be started with a complementary feeding, they can very well, the mother can include this high protein diet for the child. Frequent and periodic assessment of the child is also important at home setting or in the isolation center. At home setting, it can be done by the ASHA worker or a community nurse. Now, children with moderate illness. Children with moderate illness may suffer with a respiratory problem like pneumonia, sepsis, and acute respiratory distress syndrome. Symptoms may be associated are like difficulty in breathing, alteration in respiratory rate, and decrease in saturation level or altered saturation level. Now, in severe illness, we find that increased respiratory rate may be below 90%, high-grade fever, child vision. The child may present with altered sensorium, evidence of shock, multi-organ involvement. The child may come with seizure, decreased urine output, or cyanosis. Now, when we find this, the child with moderate and severe illness, these children need ICU care. For managing the child with ARDS, shock, and MISC in ICU, the ICU should be well equipped with necessary and functional equipment. Why I say functional? Because equipment may be present there, but the function of the equipment has to be ensured before it is used or during the use. Adequate stock of emergency medication in a proper drug dosage should be made available, and the expert team, those who are going to care for the child, which includes skilled nurses, those who have undergone the PALS and NALS course, that is pediatric advanced life support and neonatal advanced life support training. Children, when ill child, we should be aiming for the supportive care or for the outcome of the child. Nursing is nothing but it is a supportive care which provides depending upon the severity of the illness. Now, in ICU care or for the critically ill child, immediate stabilization of a distressed child is very important based on your observation or based on your assessment. This assessment will be following the ABCD protocol, and similarly, the child and the family centered care has to be, this approach has to be introduced or it has to be used along with the patient safety. So patient safety is also important. Nutritional need to be maintained. It should be met. Prevention of the complication should be taken care, and education and support for the parents, family members should be there, with proper follow-up of the child for the further complications during the hospitalization and after the discharge at home. Now, at the time of admission, what is important? Important is the nursing assessment. What is nursing assessment? A quick assessment of the child is need to be done. The quick assessment includes general appearance. You have to assess the child for consciousness, lethargy, drowsiness, airway, check for the respiratory rate, depth, pattern, symmetry, effort, and use of the muscles during the respiration. Whether the child is using effort for breathing or the child is using the external respiratory muscles for breathing. Now you have to hear for the breath sounds and the spontaneous respiration. Circulation and cerebral perfusion, check for the rate of the pulse rate or the heart rate, rhythm, skin color, temperature, capillary refill, blood pressure, and SpO2, of course. Collect past medical history, which includes the medical surgical illness along with any surgical procedure, any other illness or the disorders, maybe psychiatric disorders or the problems or allergy to any food or medications, and any medication if at all the child is taken. For example, if the child is a known seizure, child may be on anticonvulsant drug. Systemic physical examination need to be done, head to foot examination. Now, when we do this assessment, after assessment, a planning of a care is very, very important. So this planning of care will depend upon what you know, what you see, and what you find it. So knowing is medical history, social history, but even the medical interventions which are being done for the child. And same is airway, check for the airway patency, pallor, sweating, mental state, posture, facial expression, general condition. Finding is you have to monitor and find out what is the respiratory rate, adequacy of the oxygenation, pulse, blood pressure, urine output, conscious level of the child, and monitoring for the changes in any of the above. Assessment will be definitely based on the ABC model. A stands for airway patency, breathing rate, circulation for pallor, cyanosis, hemorrhage. D, visibility or altered sensorium, and E is exposed to the examining or unseen hemorrhage. Nursing management of critically ill child, which will include continuous monitoring of the child in the area. For respiratory, you are supposed to take care of the respiratory, provide a respiratory care, cardiac care, gastrointestinal care, nutritional care, neuromuscular care, comfort and reassurance to the child as well as the parent, communication with child and family, prevention and control of infection, fluid and electrolyte balance, check for the glucose balance, bowel and bladder care, and also, if at all, dressing and wound care. Now, when we talk about the continuous monitoring of a child in critical area, already these things have been dealt during the last session. Just I will brief it what is important as a part of nursing care. Monitoring of the vital signs, especially for the temperature, pulse, respiration, blood pressure, SpO2, and pain, if at all the child is presenting with a pain complaint. Temperature in these children, it may be hyperthermia, or in small babies, it may be like hypothermia. So check for the temperature properly. Pulse, respiration, of course, the respiratory system is affected here. So respiration, it will be more or it will be increased. Blood pressure depend upon the case to case, whether the blood pressure is falling down or it is increasing. Monitoring the fluid balance for hydration level. Maybe a patient which is coming with a severe illness may have a problem with a cardiac overload, or the children, those who are not eating well before they are being brought to the hospital, they may go into the dehydration level. So monitoring of the fluid balance with a proper hydration level, accurate doses of medication. Monitoring of accurate doses of medication is very important, because once the medication is started for the patient, these children, as you have seen in the last session, the drug doses calculation depends upon the weight of the child. So whether the dose is being administered in a proper calculated dose, or the flow of that fluid is being given to the patient child in a proper dose, that is very, very important. Sometimes there may be some other difficulties like occlusion or blockage of the IV cannula, or any other problem where the dosage of the medication may not be delivered to the baby. So setting of the supportive devices, if at all the child is on mechanical ventilator or non-invasive ventilation, setting of the supportive device need to be checked before or during the delivery of that particular or use of the devices. Oxygen flow rate need to be checked properly, and also checking for the complications of oxygen. So continuous monitoring throughout is very, very important, not only related to the equipment or medication or any other devices, but also on the lab values of the baby. So whenever the child is getting admitted in the ICU, you will find that majority of the lab, the blood samples will be sent for any reporting, like serum or maybe with the ABG analysis. So these lab values also have to be checked on it, and based on that it has to be reported in time, as well as the medication dosage may need to be altered based on the lab values or the patient saturation. And the second thing is taking care of the respiratory system. So respiratory care includes improving the oxygenation. So how we are going to improve the oxygenation in the child? It is obviously by administration of the oxygen to the child, maybe with the different devices depending upon the need of the child. Appropriate use of the medications if at all it is required and as per the prescription of the doctor. Monitoring of our treatment efficacy. So whatever the treatment is being given or it is being started for the child, the monitoring of that treatment is very, very important. Recognition of early warning signs for an exacerbation with the rapid access to appropriate service like ventilator, crash trolley, emergency drugs need to be kept ready in case like a moderate child who has been brought and need to be, this condition is deteriorating, we should, the ICU or the area should have a proper devices with the proper and adequate emergency drugs. So crash trolley or the other devices, whatever it is required, need to be kept ready. That is a prime duty of a nurse. Positioning of a child. Now, for improving the oxygenation, positioning helps a lot. So awake prone position. In case of newborn baby, we can give a prone position by placing the rolled towel below the abdomen or maybe below the shoulder level on the or it can be placed on the mother's lap, or it can be placed on over the pillow. Little older children, we can give support with the pillow and give them a prone position. Suctioning if required or if necessary. If there is a tracheostomy, the tracheostomy care need to be given with proper dressing and regular periodic suction. Cardiovascular care, which requires a continuous cardiac monitoring for dysarrhythmia, proper use of medication. So when we administer the medication, definitely in the last session it was dealt by the Dr. Prakruti. She has very well described how to calculate and what are the side effects of those drugs. So we have to observe for the side effects of these drugs and also administer the drug in a proper calculated or in an accurate dosage. Monitoring of the treatment efficacy, of course, it should be there. Recognition of the early warning signs, like in case of cardiovascular care, you may require a defibrillator or ECG machine or the emergency drug if necessary. And positioning for easy breathing or for improving the breathing. Gastrointestinal or the nutritional care need to be taken if at all the child is having a gastroesophageal reflux. In this case, this supine position will not work. It has to be, the child has to be placed in a propped up position or 30-degree head elevated position, so that the child will not have that gastroesophageal reflux. Usually this is present in the younger infants whose cardiac sphincter is properly not developed. Early enteral feeding may reduce infection. So, of course, the nutrition plays an important role in the child along with the medication. So, the diet has to be taken care of, and early enteral feeding need to be started so that the child gains that immunity for fighting against the diseases, as well as it reduces the stress, ulceration, and GI bleeding. These children may present with diarrhea. So there is already a fluid loss through the through diarrheal episodes, and this needs to be replaced by the fluid. It may be like IV fluid, or it may be oral fluids or liquid diet. Similarly, the immobility which is associated with the gastric stasis and constipation need to be avoided. The mobility need to be increased by giving the physiotherapy or giving maybe because the child is being on ventilator and child is on sedatives, so gastric stimulants need to be given, or maybe sometimes the child may require laxative in case of constipation. Neuromuscular care. So when the child is being admitted in the critical care area for a longer period of time, for example, like 7 to 10 days or more than that, the child is on the bed, the child requires mobility or ambulation. So this immobility, which is for a prolonged time, may prolong the neuromuscular blockage, and simultaneously the sedations which are being used, the child it may cause atrophy or joint contraction and foot drops. So therefore, physiotherapy on a regular basis, sometimes the child who requires splints may be given. Another aspect of the nursing care is comfort and reassurance. Now, comfort and reassurance, both for the child as well as the mother or the family member, is necessary. So when the child is on tubings, like various devices which is being used for the child, maybe if the child requires mechanical ventilator, so orotracheal tube, nasotracheal tube, nasogastric tube, or urinary catheter lines are there, central lines are there. So this causes pain and discomfort in the child. So the child's reaction can be seen in the form of irritability. So therefore, the child need to be comforted by proper placement of this tubing with the adhesive tape, as well as proper positioning of these tubings and securing the tubing is very important. There should not be a tension, like on urinary catheter. If there is a tension, the child may feel that pain. Nasogastric tube, again, it also hurts the child. Nasotracheal tube, it has to be fixed properly. Otherwise, it is definitely going to affect the respiration of the respiratory saturation of the child. Sedation, if required, can be given as per the order. So, the children who require a mechanical ventilation may require a sedation, or the children, those who are more agitated, may require a sedation. Parents to be assured by giving a proper explanation, by giving proper counseling. So, regular counseling of the parent is important when the child is admitted in the hospital. Allowing the parent to open up or to ventilate with their problems, and if at all, if it is possible, try to help the parents through the social worker. They may face the problem of finance, or maybe their stay, or maybe for getting medications. So this can be helped out. The parents can be helped out by talking to the parents, counseling the parents, and involving the child, a parent in the child. So when we take care of a child on ventilator, if at all the child requires a ventilator, so checking for the ventilator support, check for the compliance, check for the flow, minute ventilation, rate, and tidal volume. So that, as you have seen that Dr. Karche has discussed regarding the various equipments and the devices. So ventilator, if at all it is used for the child, the proper pediatric setting has to be, or the mode has to be changed, and after that only you can start with the ventilation. Otherwise, if it is being forgotten that which mode it is to be, it may damage the lungs. So monitoring for the acidosis, maybe respiratory, metabolic, saturation need to be checked. Hypoxemia, whether the child is going into a hypoxemic, hypercarbia, hyperoxemia. Provide a safe environment for the child while protecting the lungs from damage due to the oxygen toxicity by maintaining sufficient oxygenation and ventilation. Sedation, loading and maintenance dose to be given calculated as per the body weight per kg, and assessment of the lungs for atelectasis, expansion, air entry. So there should be a regular assessment. When we say that a nursing care is always on every time based on the assessment. Maybe a subjective and objective, but in case of critically ill child, most the objective assessment is very, very important based on your observation, what the child is presenting with, or what are the symptoms, or what is your assessment findings. Now, what is important here? The general measures by taking care of a child. Securing and fixing of the endotracheal tube is important. If displaced, then it may alter the saturation level of the child. Suctioning when required. Check for the endotracheal tube cuff pressure every 6 to 12 hourly for no leak and safe pressure. It should be maintained less than 20 centimeters of water. Ensure proper functioning of the device. No routine ventilator circuit change unless contaminated. If child is on CPAP or NIV, ensure good mask seal for no leak. Prone daily for at least 12 hourly and avoid disconnection during the pronation. Monitor complications of ventilator-induced lung injury. Extreme caution in visitation by the parents until COVID-19 negative. Now, extreme caution in visitation, that means there may be so many relatives those who wants to visit, and they may arrive in the hospital, but we have to limit only up to one single parent, or maybe mother or father. No other relatives can visit the child. But with the proper precautions, if at all they are wearing proper PPE kit, proper hand washing, they should be taught, and then they can be allowed to visit the child. Using of the audit tool like care bundles for ensuring the quality nursing care. Now, all of you may be aware of this audit tools and care bundle for quality nurse. So these can be like especially for preventing the hospital acquired infection. Of course, nutritional support is also important. This nutritional support will include adequate hydration, IV fluid therapy. If required, TPN in case of critically ill child who cannot take oral, who may be on ventilator support, maybe on Ryle's tube, oral feeds, or young infants, those who can take oral feeds. Maybe the mother should be encouraged for breastfeeding, soft diet, adequate, which includes adequate calorie, protein, vitamins, and minerals need to be taken care. Nutritional aspect has been dealt by Dr. Sindhu. She has very well explained what type of diet should be included. during hospitalization, the that plan of the child has to be properly maintained, and it has to be carried out by referring the lab values, especially for the albumin and protein level and creatinine. Now, other aspect what we usually focus in COVID is prevention and control of infection. Now, when we are taking care of a child, once the child has come with the infection, another infection should not be developed for the child. The child should not acquire any other infection or any other complication which is giving rise due to the infection from the hospital. So, use of aseptic technique is necessary while doing any of the procedure for the child. Maybe a suctioning, maybe a feeding, maybe a dressing, or anything. Monitoring sign of infection. Monitor the sign of infection. Any sign like fever or redness or tenderness or maybe pain. This should be monitored, specifically for the invasive procedures like IV cannulation. Take an example of IV cannulation. If IV cannula is there, check for the IV site infection. So VIP score can be assessed, and it can be the care can be taken care accordingly. Monitoring the intake output chart, especially for the child who is admitted with the severe illness or moderate illness, for proper functioning of the kidney. The child should not go into acute kidney injury or maybe the complications of it. Or for assessing the output or cardiac output, mobilize the secretions by positioning, physiotherapy, suctioning of ET tube. So secretions which are getting stagnant due to the immobilization need to be moved out, or it has to be removed from the lungs. So it can also reduce the infection. Maintaining hygiene. So this is a basic nursing care which includes the oral hygiene, maybe use of chlorhexidine or whatever it is according to the protocol of the hospital. Eye care, definitely by installation of normal saline, or maybe as per the prescribed eye drops. Regular eye care is also required, and closing of the eyes or eyelids to prevent the corneal damage. Skin care, of course, for avoiding the infection, and bed sore, checking for the pressure points. Now, as we have seen this nursing management, we all know that nursing management or the nursing care of a child is based on the nursing process. Nursing process includes the nursing assessment, the diagnosis, the outcome, the aim, and interventions which are carried out to achieve the outcome. So there are few nursing diagnoses in case of COVID-19. Here I could mention it, like impaired gas exchange related to increased pulmonary secretion secondary to disease process. Now in COVID-19, as we know that this disease is mainly affecting the lungs, the respiratory system, and lot of secretion is produced which alters the gas exchange. The saturation level drops down. So based on your assessment, this nursing diagnosis is made, and to achieve the outcome, the intervention need to be carried out. Second nursing diagnosis I would like to mention here is ineffective airway clearance due to the secretions, which is related to the ET obstruction, maybe, or it may be due to the displacement of the ET tube. So clearing of the airway, maintaining the patent airway is the objective, and the interventions required is necessary. Hyperthermia, the children may present with the fever, so hyperthermia related to COVID infection. Next is altered cardiac output related to the hypoxia, may be decreased or it may be increased. So depending upon, mostly the children may present with a decreased cardiac output. Another one is restlessness related to the hypoxia. These children may present with irritability, and they are usually restless due to the devices which has been used or the new situation like hospitalization, new environment, and separation anxiety. Now Other diagnosis which we can think of is potential for the difficulty in weaning. So if a child who is on ventilator support, it may be related to the failure of the resolution of the pulmonary disease due to COVID-19. So these are few diagnoses which I have mentioned here. Based on that, the intervention can be planned and carried out for achieving the objective. Now, prevention of COVID-19, which is very much required. How we are going to prevent this COVID-19? Even in the children, safe distance need to be maintained, and the children they vary from newborn to adolescent. So education to the mother as well as the child who can understand, the education to the child, explanation to the child is also required. So maintaining safe distance by the parents, even by the child, if you teach the child. Wearing of mask. Wearing of mask is some of the children they may not like it wearing the mask. Some of the children they may like to wear a mask. So you have to explain the child, tell the child to wear a mask. Even parents need to be taught that whenever they are taking the child out, they have to cover the baby's mouth with the mask. Use of sanitizer, washing hands frequently while handling the children, and especially restricting the people those who are handling the child. Like if the parents, parents who are there at home, they can only handle the child. If elderlies are there or the person who is infected with COVID-19 should be avoiding the handling of the child. Home and environmental cleanliness is another aspect at home setting, so that the child will not acquire this infection. And talking about the vaccination, nowadays the vaccination is on trial, and we hope that this vaccination is permitted for all the children, and we may not have to face this third wave of COVID-19, which is specifically for the children. So I hope this vaccination will be released by the government and it will be made available for all the children. Now, summarizing my topic, the most important here is the nursing care of a critically ill child. When we talk about the nursing care is nothing but it is a supportive care. It may vary in this COVID-19 as the child present with the mild symptom to severe symptoms. So depending upon the symptoms, the child can be managed at home by providing a proper education to the parents. If the parents have been given a proper instruction and regular follow-up of this child for the early identification for the deterioration of the condition. Moderate to severe symptoms require hospitalization, and once they are hospitalized, the nursing care starts. So nursing care along with the medical management with the proper monitoring of the child's condition and supportive care like adequate nutrition, prevention of infection can help for the early recovery of the child. Educating parents for proper care and prevention of the complications even after discharge is also important, because nowadays we can see that majority of the babies, they may come with multi-system inflammatory syndrome, which we are started getting this. Even we have got a child who has been detected, a 9-month-old child who is detected with the COVID-19 infection, and that child had fever for 2 to 3 days. Mother was not feeding properly to the child, though the child's weight is appropriate for the child's age, but still the child was able to take. But in this case, during the illness, what happens if the child does not take proper feed? So children are more prone to get dehydrated. So that has to be taken care. The medication as per the protocol of COVID-19 and as per the prescription of the doctor, it should be administered properly. Another case like multi-inflammatory system, multi-system inflammatory syndrome. These cases are also have started coming to the hospital. So we have a child who is 15-year-old female child who has been admitted in PICU, and presently when she had come in a drowsy state where her blood sugar was very high, above 300, and after coming here, when her COVID-19 antibody test was done, it was found to be antibodies were present. So maybe this is a post-COVID multi-system inflammatory syndrome, and we are suspecting, according to that, the medications have been started. The child is on ventilator support. So the care of the child in ICU, it is completely the patient or the child is dependent on the nurse. So the nursing care starts from the basic to the advanced for proper monitoring, proper care for the infection, prevention of the infection. So there are few studies which have presented with the COVID-19. These are the few references of the studies which says that boys are more commonly affected than the females. Even children, COVID-19 is detected. Maybe 1% or less than 10% are symptomatic. So I would say that the nursing care is very, very important once the child is, and all nurses need to be prepared for the care. So I end up with my session. Hope this may be useful for you. Thank you very much.
Thank you, ma'am. Really, it was a wonderful session, and it was, as well as it was helpful for all the nurses, those who attended the webinar. Thank you, ma'am. Next, we'll
Thank you.
move towards the next session. Which is about the practicals, resuscitation of the children related in the COVID-19. So the session will be dealt by Dr. Priyanka A. Amunkar. She has completed her MBBS MD in 2020 from MGM Medical College and Hospital. She had been a part of international educational visits during the education for 3 months. She has BLS and ACLS certification. She also has done research publication and currently working as a senior resident in MGM MCH. Another speaker is Dr. Amol Madhve, who is a pediatric nephrology, who has done a pediatric nephrology training from CMC Vellore. Is a teaching faculty of pediatric and pediatric nephrologist at MGM Medical College and Group of Hospitals, Navi Mumbai. He has a life membership of the Kidney Foundation for Children, which is a non-profitable organization for children with kidney diseases. He is a national coordinator of International Pediatric Nephrology Association and Indian Society of Pediatric Nephrology and Renal Transplant Therapy Registry. Over to you.
Good afternoon, everyone. I'll be talking on resuscitation in COVID children and the specific measures that we have to take to protect healthcare workers who are involved in giving high quality CPR. So the purpose of this talk is to highlight what are the measures that a person who's providing CPR needs to take. So resuscitation in COVID child poses significant risk for healthcare workers, generation, and highly contagious nature of the virus. So the Indian Academy of Pediatrics Advanced Life Support Basic, that is IAP, ALS and BLS, has come up with 10 recommendations on the general principles for resuscitation to be followed during COVID pandemic. So starting, the first and most important is protect yourself before starting chest compressions. So PCAB, generally we follow the C. In a COVID child, we have to protect ourselves first. So the healthcare worker should don full personal protective equipment whenever he is resuscitating COVID area. If suppose the resuscitation is occurring in a suspect area, there also you have to assume that the patient is COVID positive and follow the same procedures. In view of this ongoing pandemic, it is recommended that even in a non-COVID area, preferably one should use either full PPE or at least double gloves, eye gear, and an N95 while performing CPR. So the basic recommendations are, first is compression CPR should be provided until the victim's airway is secured. The victim's airway should be covered either using a face or a mask before you perform compressions. Do not give mouth to mouth or mouth to mask ventilation. In view, again, like I said, in case of out of hospital cardiac arrest, irrespective of the history of the patient, you have to cover the patient's face with a mask or piece to start compressions. So these are the details of additional equipment that are required to be present in a crash cart while performing CPR. So PPE for providers, the basic contents are: first is a non-permeable head-to-toe coverall. Second would be goggles and face shield that covers the sides of the face, very important. N95 mask, splash gown or apron, double gloves, and plastic or rubber footwear. Protective items in addition to this are face shield or surgical mask, that is while the victim's airway has not been secured, and aerosol box or a plastic drape to cover the face until advanced airway is in place. Other things which are specific in a COVID case are use of a video laryngoscope. Second is the use of a viral filter or HME filter, about which I'll be talking in the later part of my talk. A closed system suction device, ETCO2 monitor, and surgical airway kit. So this is an aerosol box. Wherever available, it should be used while performing chest compressions. Securing the patient's airway. Secure the airway using a tracheal tube or a laryngeal mask airway. To minimize exposure, connect a viral filter or a heat moisture exchanger with viral filtering capacity between the ET tube and mask, or if we are going to before we connect it to a ventilator, at the Y end of the ventilator tube. In out of hospital setting, again we can use filter which is connected to the bag and mask, and tight seal to minimize air leak. So here we can see that the viral filter can be at both bag and mask as well as to your ventilator tubing. So this is an HME on the right side. Restrictive team composition. So this is also very important. In non-AO, the CPR team consists of a 6-member team. However, in COVID situation, it has been reduced to 3 to minimize the number of people that are being exposed to this high-risk procedure. So first, role 1 is of the person who's managing the airway. So he will be the one providing breaths. Role 2 is of the compressor. And role 3 is of the automated external defibrillator, who will also be administering medications. So the third person is to alternate with the second person to provide other team members who are responsible for recording events or counseling should be at a safe distance from the site of resuscitation. And healthcare workers above 60 years of age or having comorbidities should not participate in this procedure. Families or friends' presence is also not recommended. Video teleconsultation can be allowed later. Tracheal tube placement. So, preferably a laryngoscope should be used, or a LMA should be used, or else direct laryngoscope. In case the above is not available, we can use a direct laryngoscope. However, protective measures are extremely important. Stop chest compressions while intubating. After the patient is intubated, a cuff tube is preferred, and inflate the cuff immediately on insertion. After the tube is, you can attach a viral filter, and then this tube can be connected either to a bag and mask or to the ventilator. Again, very important is use closed suction system. So we have to prevent aerosolization as much as possible and avoid auscultation to check whether tube is in place. Preferably, a ETCO2 detector should be used. Attach to ventilator early. So connect to a mechanical ventilator once the advanced airway is in place. Deliver chest compressions at a rate of 100 to 120 per minute without pause, and breaths by a ventilator at a rate of 10 to 20 per minute and 12 to 20 per minute in children. AED and defibrillator. So the cardiac arrest algorithm provided by IAP BLS should be used. Another thing which is important is if it is preferable to use a to deliver shock. In children, dose attenuated AED is preferred, and pads may be applied in the anterior posterior position in prone ventilated children. So CPR in prone position. In case the patient is in the prone position already being ventilated, CPR can be given in this position as well. I will be showing you an image of how it is to be done. Position the hand just below the subscapular line over T7 to T10 vertebra while giving compressions. Compressions are given at the same rate, that is 100 to 120 per minute, and force will be sufficient enough to compress 1/3 of the anteroposterior diameter of the chest. So here we can see this is a patient who's being ventilated or lying in the prone position. So location of the compression is 2 hands. So there are 2 ways of doing it. One is the 2 hand together method, where we place it at the T7 level of the inferior. Another method is 2 hands apart method, where 1 hand on either side of the spine at the same level as above can be given. While placing the AEDs, so we have one is the posterior apical position, and the second is the second pad is to be placed at the posterior anterior position, as we can see in the image below. Hypomagnesemia. So hypomagnesemia is an important correctable cause of ventricular arrhythmia in COVID-19 cases. Although now the use of hydroxychloroquine and azithromycin has reduced, but these 2 drugs are very likely to predispose the patient to ventricular arrhythmias like torsades. Hence, magnesium sulfate infusion during resuscitation should be considered, and magnesium sulfate should be added as a part of the crash cart. Early use of vasoactive drugs. Once return of spontaneous circulation is achieved, consider early vasoactive drugs for persisting shock. Avoid aggressive fluid resuscitation. Appropriateness of resuscitation and duration of CPR. So it is recommended to follow the hospital. One has to take into consideration the stage of the disease and those with comorbidities. Possible outcome may be considered while deciding continuation or termination of CPR. Since this should be discussed among healthcare workers and communicated to the parents or the proxy of the patient. So just briefly talking about the differences in resuscitation as compared to adults. So as you can see, the location where we place the hand in children 1 to 8 years of age, and in case of an infant, CPR can be given using the 2-finger technique. In case of children, we have to press down 2 inches, similar to that in adults, that is 1/3 of the anterior posterior diameter. In case of children, 1.5 inches. So if there are if two rescuers are present, the ratio of chest compressions is to breath is 30:2. So and 100 to 120 compressions per minute should be given. So algorithm, the text written in red highlights what is different and specific for a COVID child. So first, most important is to verify the scene safety yourself and assess the risk of COVID-19 transmission. So first, what we have to consider is, are we in a COVID area or are we in a non-COVID area? Then if the patient is unresponsive, we have to activate the emergency response team composition. Like I said, only 3 members. And following this, the other things are similar that of your regular CPR, that is assess whether the patient is breathing and whether pulse is present. If normal breathing and pulse is present, place the patient in recovery position and continue monitoring. If there is no normal breathing but pulse is present, then secure airway and give rescue breaths. If the heart rate falls below 60, compressions are to be started. If there is no breathing and no pulse, initially this is the important part where only compressions are to be given until the airway is secure. Then you can continue with high quality CPR and check for the rhythm. If the rhythm is shockable, shock can be given. If it is not, so this from here downwards, you have to follow the cardiac arrest algorithm. So in cardiac arrest, again, I would like to highlight that compressions only CPR until the airway is secure. And rest of the things are similar to your regular CPR, where you check whether rhythm is shockable or not. If shockable, you give shock. If it is a non-shockable rhythm, then continue chest compressions for 2 minutes and then reassess. So summarizing the 10 recommendations on CPR, first is protect yourself before starting chest compressions. Follow the PCAB sequence. Secondly, secure airway to minimize the exposure risk. Restrict team composition to triangle of resuscitators. Practice additional care while placement of tracheal tube. Attach to ventilator early. Preferably use AED. If defibrillator pads are available, use pads in place of conventional paddles. Consider the seventh test, that is hypomagnesemia. CPR can be given in prone position as well while the advanced airway is in place. Use of vasoactive drugs and restricted use of fluids, and consideration of appropriateness of starting and continue, how long the CPR is to be continued. Thank you. Now, Dr. Amol Madhya will be continuing with the rest of the talk.
Thank you, Dr. Priyanka. So we move forward. I think for my talk, Dr. Suhas, Dr. Prakriti, and Dr. Priyanka have made it easy for me to take this concluding talk of our. I won't take long. So what we are going to discuss now are the practical tips on resuscitation in COVID in children. So all of us have heard all the theory lectures about what oxygen devices are there, what resuscitated devices are there, what drugs are to be used, and how do we go about resuscitating a child. So it's basically like reading a cookbook or a recipe book and then trying to cook. So these are the practical tips on how do we go ahead with resuscitation. Before we go ahead, there are certain or certain what do we say, speed breakers while going ahead with pediatric resuscitation. The first and foremost reason is inadequate exposure to critical care of children. As a nursing student or as a working staff, we hardly get posted in pediatrics. Only if we are posted in pediatrics, we know about details of what is to be done with children. So we usually are a little skeptical when we are posted in pediatric COVID ward. Secondly, we all have this concept that pediatrics means never-ending, a lot of drug calculations, lot of addition, multiplication. We use are different for all different children depending on their. So is this visible to all?
Yes, sir.
Okay. So we were talking about pediatric high dependency unit where we have borderline children and the pediatric ICU. All I have to remember is the situations in all these three places, the manpower that is available, both in terms of medical manpower as well as nursing manpower, and the equipment that is available at these three different locations different. So we need to be prepared anywhere in the hospital in either of these three situations. Now what happens is the COVID resuscitation is entirely different from a normal resuscitation that we take care in the emergency or in casualty or the ICU, because there is limit, because nurses as well as doctors are limited posted in the COVID wards. Also, we have to take care that not everybody is exposed to this resuscitative procedure, that is because risk of infection and aerosol generation is present. But at the same time, we also need to keep in mind that we do not compromise the quality of resuscitation. So first and foremost important things are the vital signs that we monitor. So my vital signs vary for every child. The normal value is different. Also, second point important is cardiac arrest is almost every time secondary to a respiratory arrest, as opposed to adults. A child who will desaturate or go into arrest, first beginning event is usually respiratory as opposed to cardiac. That's why it is important that before bradycardia happens, there will definitely be a saturation or increased respiratory effort that we need to monitor. Also important is to identify these at-risk children, who are these extremely high-risk children who can go into respiratory failure. And one important thing that we have observed is we have to respect the alarm. Whoever it is, either the doctor or the sister or the nursing staff has to respect the alarm. For what devices are put, if the alarm is going on, do not just go and mute the alarm and turn your back to the alarm. See why the alarm is going on. Is there some problem with the equipment or the problem with the patient? We always do not need to remember the normal signs. So this is a representative table that can be put up in any pediatric ward or ICU to know what the normal heart rate, blood pressure, and respiratory rate is. And we keep in mind and follow and monitor these children accordingly. Now, what about equipment selection? So we always need not remember what size of equipment is needed. Chart is present, which I will enlarge here and show you all. So for example, if I have a child who's about 2.5 years, weighing 15 kilos, this is the chart that is given. Airway I need to use. So that's a small airway I need to use. If I have to intubate this child, I will use a Miller 1 blade and a 4.5 to 5 size endotracheal tube and an 8 French Foley that is. So we do not need to remember these values. These can be stuck as and when required, can be referred to when we need to resuscitate these children. What about dose? Difficulty in remembering doses, because we have to multiply and divide and know the calculation like Dr. Prakriti said. Plus, there is a lot of 10 stuff working when a child crashes. So we end up making mistake and making medication errors either by giving the wrong drug or giving the wrong dose. So we have to always have pre-calculated doses for a given child, which I will show how to do, so that these medication errors reduce in number and frequency. This is a crash usually there. Now we all know that different drawers in the crash cart have different equipment. Like some drawers will have only the medication, some will have airway equipment, some will have vascular access. One modification that we can make in this crash cart for a pediatric group is probably have different drawers for a different weight band. Meaning what? Upper drawer maybe till about 5 kgs, the second drawer for 5 to 10 kgs, and so on and so forth with 5 kg differences, so that once we open a drawer, equipment that is needed and the medicines needed for that particular age group are available in that drawer, and it would make our life much easier. This is just, for example, we could have such drug and equipment card placed by every patient in the ICU and HDU, so that if the patient crashes, we don't have to think much about how much drug is to be given to this patient. We have the name of the patient, age and weight. Prakriti ma'am said all drugs are to be given based on weight or on body surface area. So we can enter the weight of the child, and I've just put in an example of some drugs and some equipments which can be used and pre-filled. This form can be pre-filled and countersigned by in-charge faculty. More importantly, if we could write our doses in ml, it would be easier for us by standard preparation. Most of the drugs are standard preparations, and drugs, if written in ml, help us in easy administration of these drugs. I've given this example of a child who's about 2.5 years old, who's 10 kgs. And if such a card is already filled and kept by his bedside, it is easier for us to know how much drug has to be given and what size of equipment has to be used. Now, what happens on a normal day is if some patient crashes, somebody shouts in the ward that the patient has crashed, and all of us start running towards the patient. But in COVID, this is not what is to be done. As Dr. Priyanka said, that we have to limit the number of rescuers that go during resuscitation of a COVID patient. We need to have limited at the max to go for a resuscitation in a COVID day. So what happens in a COVID situation is we should have an isolated area for resuscitation. This is the bed that you all can see, the dark side, that is the head end. As soon as the patient is wheeled in here or brought on a stretcher or on a trolley here, everybody should be ready. There should be an isolated, identified red zone where will take place, which is the high risk zone for aerosol generation. There should be a warm zone from where all the help will pour in. These 3 resuscitators who enter the occupy their position and start resuscitating. The crash cart can either be kept in the red zone or later on wheeled inside the warm zone. To arrive has to be the team leader, which can be a senior nurse or a doctor, who's responsible for securing and maintaining the airway. The second person could be a senior nurse who comes and stands on the left-hand side of the patient, secures the IV access, gives drugs. And the third person could be another nurse who will help in securing the airway and airway assistance. We could have a 4th person standing by who could be a resident or a student nurse who communicates with the inside team and communicates with the relatives and the parents who are outside in the green zone. So this, in short, is the way how we can effectively, with less effort and with ease, help to resuscitate the child without compromise of CPR. Thank you.
Thank you, sir. It was a great session conducted by you. Further, we'll move towards the question and answer session. So I would request all the panelists to be ready for the question and answer session. We have some questions raised by the attendees. So the first question is, why the HFNC is contraindicated in O2 retention? So it was given by one of the attendees whose name is not mentioned. I'll repeat the question again. Why HFNC is contraindicated in CO2 retention?
I think Dr. Suhas is not able to join us. So I have not come across any situation where a HFNC is contraindicated in CO2 retention. HFNC can help us reduce a lot of distress that is there to the patient, and it will help us in achieving treating the hypoxia. The hypoxia gets cleared, I think the CO2 will also start getting washed off. So to my knowledge, I have not come across anything that is contraindicated, like an HFNC indicated in CO2 retention.
Thank you, sir. Our second question was asked by two of the attendees. That is, if the mother is positive and admitted in ICU, and whereas the child is been kept in the other ward, or child is being kept as separate. So, how to manage the situation?
Thank you for the question. Actually, when we need to understand that when a mother is in COVID ICU, that mother is under a lot of medications. It can be antifungal, antivirus, anticoagulants, antibiotics. A group of drugs are there for that particular mother. So when we assess the risk and benefit ratio of the mother, we want the mother's physical stabilization first than going for a breastfeeding, because then breastfeeding becomes a second category of priority. So we need to understand that we really don't know the drugs what we are using on COVID can be mainly of trial-based drug, where we really don't know how it can affect the child, because which all drug can transmit through the breast milk and it can hamper the baby immediately or later in life. So it is a safe that we are not breastfeeding the child and the mother is in COVID treatment, and once the mother is stabilized and moved out of from the ICU or HDU, then we can restart. Till that time, if there is a lot of milk production is there in the mother, we can suppress the lactation. If not, the expression of breast milk is encouraged if less amount of breast milk is produced. Hope I answered the question. Thank you.
Thank you, ma'am. Our third question is, what measures are taken in hospital related to disposal of COVID waste?
Yeah, Ms. Dipali, this question is regarding the COVID waste. Now, in our hospital,
Yes,
what we are doing is the COVID waste is collected separately, though the guidelines are given. So, as per the guidelines, we are collecting the waste. Now, here the most common waste, and it is collected in the huge amount to the PPE kit, cap, mask. So this is being collected in a yellow bag, which carries all infected PPE kit, cap, mask, and the other shield, and it is disposed. So what we are doing in our hospital, that we have outsourced the waste disposal, and we have got that certificate of pollution control, and this RAMKey, which we have hired, the outsourced, they take waste and they dispose it off as per the guideline. So here we don't have a facility to dispose, but we collect the waste and we give it to the person. Every day these waste come for collection of the garbage and the waste, biomedical waste of COVID, and it will be disposed of. Second thing is this COVID waste, it is separated from the other waste. In case of like other waste which is generated, now in COVID, we have labeled the container red, yellow, and black, which is collected from the COVID wards. And then it will be disposed of. The person who is disposing or collecting from the ward is also wearing a PPE kit, and it will go and dispose it off at the common point. And from there, it will be collected. Another thing is linen. So this linen is been first decontaminated with hypochlorite solution, and then only it will be washed in the laundry in a separate laundry machine at a separate timing. It will not be mixed with the other linen, and it is separately washed and it is being given. So that is the way how we collect the and it is disposed of. Hope you must have satisfied with the answer.
Thank you, ma'am. So here we are at the end of the web.
Dipali, there is one more is there regarding neonate. Neonate with
Yes.
COVID positive.
There is a question of neonate with if the neonate is of COVID positive and the mother is COVID negative, does it require hospitalization for the baby with no symptoms?
Unless the baby is not symptomatic and there is provision for isolating the mother and the baby together, we can discharge the child. Of course, we will emphasize on the continuation of breastfeeding, mother continue to wear mask, and red flags will be explained to the mother, red flag signs. So these are the signs which will tell that the baby might get hospitalized in future. There is no indication to keep the baby admitted. After routine PHC this is completed, we can discharge the baby, advising them home isolation.
Thank you, ma'am. Hope all the questions are clear. So we are at the end of for vote of thanks. So on behalf of MGM New Bombay College of Nursing, I am Ms. Dipali Pingre. Take a privilege to give vote of thanks for the 2 days of webinar on management of children with COVID-19. Firstly, I would like to thank Dr. Vijay Kamale, HOD of Pediatric Department, and Dr. Prabhakar Desirla, Director and Professor of MGM New Bombay College of Nursing, for taking initiative to organize the workshop. Secondly, I thank all the panelists of Pediatric Department from MGM Hospital Kamothe and MGM New Bombay College of Nursing Kamothe that are Dr. Jitendra Gavane, Professor of Pediatric Department, Dr. Revati N, Associate Professor of Pediatric Department, Dr. Suhas Karche, Assistant Professor, Pediatric Department, Dr. Prakruti KD, Assistant Professor, Pediatric Department, Dr. Sindhu Thomas, Assistant Professor, MGM New Bombay College of Nursing, Dr. Padmaja Dawale, Associate Professor, MGM New Bombay College of Nursing, Dr. Amol Madhave, Assistant Professor, Pediatric Department, and Dr. Priyanka Amunkar, Senior Resident, Pediatric Department. So to make this webinar very informative and clearing all the doubts, I thank all the panelists. Next, I would like to thank the IT department, Mr. Anil and Mr. Nitin, for their support. Last but not the least, I thank all the attendees, those who have participated in the webinar, without whom the webinar would not be completed. Thank you. Once again, thank you all for the attending of the webinar. The feedback link has been posted in the chat box. Kindly fill the feedback form.
Thank you, sir.
Preeti, just take the photograph of all the panelists, those who are available.
The feedback
Dipali.
form, filling a feedback form is mandatory for issuing the certificate. So kindly fill the feedback form.
Dipali, tell them to on the.
I request all the panelists to on their videos for a photograph. Okay, thank you once again, all the panelists and all the attendees to attend these 2 days of workshop.
Thank you, sir. Thank you.
Thank you.
Thank you, everyone.
Thank you.
Thank you, ma'am.